So I wanted to go over another favorite pharmacist intervention. This one was when I was on rotations at a primary care clinic. It was primarily an underserved clinic. It had like a sliding scale kind of fee system. So I did see a lot of uninsured and Hispanic patients. So I had one patient who was given Ceftriaxone intramuscularly. He was on his third day, his third shot, and I was curious and I asked the medical assistant, what's that for? Because I saw them mixing it with lidocaine. I thought that was interesting. And I looked at this chart and I figured out this man was recently discharged with MRSA BSI. So he had a bloodstream infection, a bacteremia, with a positive MRSA culture, methicillin-resistant Staph aureus. So I was immediately oh my God, well, Ceftriaxone has no coverage against MRSA. Why are we giving this man Ceftriaxone? Why is he getting his third shot? What's going on? So I dug deeper into the discharge report, and it looks like he was discharged with Augmentin and Bactrim. Bactrim has MRSA coverage, Augmentin doesn't, but he had a concomitant cellulitis, so that's what the Augmentin was for. And apparently he was throwing up his medicine, so he stopped taking what he was prescribed outpatient and came to this center, and the physician there decided to give him Ceftriaxone. So I went to the physician and I was like, hey, to my knowledge, this has no coverage. What's your line of thinking? Does it actually have coverage? What's going on here? And she pulled up an article and the title said methicillin susceptible Staph aureus and Ceftriaxone. And I pointed out that's MSSA, not MRSA. And I recommended alternative therapy. I recommended linezolid. It's not a common medication that I see. It's pretty expensive outpatient. I found a good RX for it. It's $30-something. But I intervened in that case. This patient was a poorly controlled diabetic with a previous past medical history of osteomyelitis, which is a bone infection. So he's had sort of these serious infections before. He had a toe amputation in the past. So I would classify him as a high-risk patient. He originally got IV antibiotics in the hospital, but he left AMA because he had to go to work. That's not entirely uncommon in Indianapolis, but I counseled him on what to watch out for side effect-wise with the linezolid, but also with progression with his disease state, if he didn't improve. Because by the time I saw him, he was around day 10, I think, on his antibiotic therapy. And he didn't seem to be improving. He had some back pain and some malaise still. But that was sort of my intervention there. I was a student. But I think about it a little bit every now and then.